Our topic today is role of scoring balloon in complex PCI. We hope this webinar will bring you new insights and tricks on optimizing PCI procedures. Now let me introduce today's participants. They are our honored guest speaker, Dr. Azhari Rosman at the National Heart Institute of Malaysia. Welcome.
Once again, thanks to BrosMed for giving me this opportunity to share my clinical experience. Clearly, in the short space of time, we don't have the scope to cover every aspect of your NC balloon, Wedge NC balloon, but clearly it has made a lot of difference in our practice in cardiology, certainly in our institute in Kuala Lumpur, Malaysia here. So as you know, I'm working at the National Heart Institute here, and we are a tertiary referral center in Malaysia. So today's brief is actually to share some cases. You were supposed to get some introductory slides about your Wedge NC balloon, but unfortunately, because of the transmission problems, we will skip that. I'm sure many of your staff are familiar with it anyway. So this Wedge NC balloon has made a lot of difference in terms of its design. And as you know, the design is quite unique because it has balloon, one-wire balloon, and subsequently with that, it's able to cross lesions better. It is also an NC balloon, which means it can go up to higher pressures. And of course, it has a very high tolerance for recrossing and reinflations, which is very good for us. So I don't have any disclosures. I have received honoraria for this talk. So as you know, and I'm glad I put this picture in because this gives you an idea of how the balloon looks like. You're familiar with all of you are familiar with this balloon. It's got one wire which is fixed, and it's got the guide wire, 014 guide wire inside the balloon assembly itself. And as a result, it's a very secure. It is a one-to-one torque if I need to turn this nitronal wire to either side, either degree, in order to achieve better cutting. So that's an added advantage. Now let's look at case number one. In this case, illustration looks at ostial area lesion, bifurcation area, which is left main and LAD. It looks at the crossability of balloon and the thrombus, which was present post-preparation, post-inflation because of the incision by the balloon. And of course, the role of IVUS, which is important in some lesions. Now, I know that IVUS is always a cost issue, but if you are able to afford IVUS, it will be a useful addition in some challenging lesions, at least to assess the morphology and the size of the vessel. So in this case, he's a 76-year-old male, he's diabetic, hypertensive, he's got a history of dyslipidemia, and his HbA1c is about 7.2, the stress echo done in 2021, which is normal. Unfortunately, he does have coronary artery disease as evidenced by the PET scan because it showed moderate ischemia. So this LAD territory, left anterior descending territory, very important area, and we proceeded to do a coronary angiogram for him. Now this gentleman, as you can see, has got a tight narrowing, very close to the left main on the left there, and it's a very short left main. Of course, the vessel itself is diseased. It's a very big vessel, circumflex, but some small, some big areas, it's a very ectatic and an aneurysmal vessel. So the strategy here is actually to have a good lesion preparation now. That's where the decision to use what sort of device comes in. And of course, to avoid left main stem injury. So the delivery of energy has to be focused and exact. The idea is to use a stent rather than the DCB because clearly it's a proximal lesion, it's important, and this is where stents are most useful. But if you can see on this picture on the right, these are the lesions. These are the vessels and the lesions in various places. There's a very tortuous LAD lesion there, and some big, some small. It's all disease. So you don't know which part is a normal reference point. And this is where IVUS comes in because IVUS tells you, okay, this looks pretty normal. This is the size, 3.5 or 3.75 or 3.0, whatever. So it gives you an idea from where to put the stent. Yeah? You don't have to put the stent too far down in the aneurysmal segment, and it becomes too big for the stent and causes thrombi. So these are the issues. It's got aneurysmal areas, ectatic vessels, severe ostial LAD stenosis. You can see here, heavy plaque burden, lots of plaque in there. It's very close to the short left main. It's got multiple disease areas along the entire left coronary artery system, and we're not sure where the distal reference is. So there is a question whether your IVUS enter this lesion, because it may be too tight to actually enter this lesion. So indeed, it was tight. So we proceeded to look at the lesion again, and you can see the balloon before the IVUS, and we'll talk about the balloon in a short while. But you can see the LED here, aneurysmal ectatic in the left spider view. You can see the left main stem, circumflex vessel here, and this is another view again. These are a slightly different view, slightly different angulation, but there's a tight stenosis in the LED, heavy plaque burden on either side, and the circumflex with aneurysmal, some small, some big, various sizes. So this has to be ballooned before we put an IVUS in, because it takes it's almost a 90-degree takeoff from the left main stem. These are the issues that I raised earlier on. So this is the IVUS frame. We managed to balloon with a cutting balloon, and this is where the wedge comes in. We actually use a cutting balloon to actually interrogate this lesion, as opposed to using a normal balloon. And the reason for that is because we wanted to be sure that the dissection is controlled and went in the right direction. There's a circumflex wire on the top, and then there's the LED wire here with the IVUS catheter. You can see with the black dot there. So this is the IVUS run. So the IVUS run starts from the distal part there. That's reasonably normal, although then subsequently there's a lot of plaque that you can see, fibrocalcific, some bright areas with black. You can see dark shadows because of the calcium beyond. And of course, you can see here about 300-degree calcific ring, and the vessel starts to become bigger. You can see here it's almost aneurysmal. And here it's about 1, 2, 3, about 4.5 diameter, millimeters in diameter across. It's getting certain points, and at some points it becomes narrow, and you can see the calcium here start to become obvious in a short while. A lot of fibrous tissue, some calcium areas here. This is where the ostium is. The second wire and in the circumflex is visible. This is the catheter already. So here is the still picture showing that the left main is about 4.7 diameter, is elliptical. And the distal reference, the normal segment far down there, where it's almost normal as it is possible, is about 3.5 millimeters. So our vessel in this LED is about 3.5 millimeters in diameter. So that's what we're going to go with. So these aneurysmal segments are big, but we're not going to stand into the aneurysmal segment. So now, the reason why I wanted to show the IVUS is because there's a type of calcium. This is another patient, by the way, that has severe calcific distribution. And this is a distribution along a 360-degree curve. You can see here there is zero, where there's no reflections, no reverberations, no transmission of ultrasound waves, because not only is it thick, it is also circumferential. So there are no reverberations. Completely, the image on the right here, completely black, because the calcium is preventing the ultrasonic waves from going through. So this is a different lesion, but the problem is, I wanted to highlight this kind of lesion because these kind of lesions may not be able to take the scoring balloon, any form of scoring balloon for that matter, because you probably need a rotablation or OAS artery to actually open this. But this gives you an idea of what to avoid and when to move on. Because otherwise, if you use balloons, you can cause a dissection, and then you can't put a stent, you can't bail out. So the narrowing is fixed, and then you get damage to the vessels on either side of the narrowing. So that can be quite a problem. So here is the profiles of the various balloons. Comparison, the Wedge NC BrosMed balloon is about 0.034 as opposed to your next common Scoreflex balloon, which is a 0.47, but it gets a bit bigger because it's got this guide wire which you have to fit outside an additional wire diameter. So it's a bit bigger compared to this is Scoreflex NC here on the right, 0.034. Pretty much almost the same, but you have a guide wire again in addition to the diameter of the balloon. Okay, so and that's a little added diameter size, but in any event, these are very well used spring balloons. So here is the image on the leftmost picture. You can see how easy it is to pass to the 2.5 Scoreflex balloon. Now we decided to use a Scoreflex rather than a normal balloon to open because I think it gives you the wedge to as a first balloon, as first choice, first inflation, unexpected dissections backwards into the left main, and the dissection can be quite problematic in a left main, a short left main such as this one. So we use 2.5 wedge, and you can see on the left here, it goes in very easily, no issues there, no kickback of the catheter also. So we use a 2.5 at nominal pressures, 2 inflations, and we know that, as you can see from the vessel size, is about 3.5. That is a reference, remember I mentioned. So the diameter of the next choice balloon upwards will be 3.5. So we use 3.5 at 12 atmospheres nominal. Now notice we didn't go to very high pressures, although the growth of your atmospheres, but we didn't do that because we wanted just enough to cut the plaque and thereby put in a stent, which is the primary objective. So now, if you look at the IVUS after 2.5 millimeter wedge, which is choice, you can see that already there are potential problems. You can see that the MLA now is 5.31 bigger. However, there's a thrombus there on the IVUS. This is a 60 megahertz IVUS. So it gives you a good idea of the image. So you can see the thrombus actually in the inferior at 6 o'clock. And you can see that it's a jagged edge somewhat. But this is the aneurysmal segment just after the balloon. You can see that after the snaring, which is a large vessel about 5.5. So this is not the size that you really want because it's already damaged with positive remodeling. So these are some points about lesion preparation. We use escalating inflations, 8, 12, 16. Do several multiple inflations. If you're not happy, you can draw the catheter into the guiding, turn it around by about a few degrees, and then you can put it back in and then inflate again. That way you can, I find it very useful. So why is the scoring balloon? We discussed this earlier. We want this control and expect it to be in the right direction before we put a stent, because you can see the amount of plaque, plaque. If we don't open it well, there is a risk of instant restenosis. Worse still, there's a risk of thrombus. But even with the trio balloon, you can see, remember, the vessel reference is 3.5, but we use 3.0, a little bit under. And so, but we've managed to modify this plaque, modify this lesion and the vessel. You can see there are flaps left and right, up and down on either side of this image. And these are the dissections, and these are potentially thrombogenic dissections. So you don't wait too long with it. But this is with an injection of contrast during the inflation to make sure that we've gone just at the mouth of the LAD and not into the left main stem. You can see that there's still good contrast into the circumflex. So let's move to the next and see again, this is the ostium of the LAD. This is a Science Sierra 3.5 millimeter, which is what the reference was. And you can see this is the inflation. Again, the contrast injection to make sure that there is no occlusion or back migration of the stent into the left main stem. But you can So in comparison, these are the images you can see before at the start of the exercise, and you can see here, this is following the stent balloon. It looks a little bit mismatched here, but then the reason is because this is an aneurysmal segment. Remember, it's about jut into that because the post optimization with the 3.5 millimeter, 20 atmospheres, and subsequently with the 4O. Into the left anterosonic ostium. So because of the proximity and the important vessel, we use clopidogrel and ticagrelor as opposed to clopidogrel and aspirin for this patient. Now, again, these are the final images. Again, this is the ectatic LED vessel you can see earlier with the circumflex wire in place as a precaution. This is a stent optimization with a 4.0 times 8 millimeter at 12 atmospheres, just nominal. And so this gives you a reason. It still looks as though there's a mismatch, but that's because the distal to that is a very big vessel. But the stent is well expanded, and I'll show you that in a minute. And that's possible only because you prepared the lesion well. So this is the image of the IVUS. Again, you can see the plaque on this is further down near the aneurysmal segment. We didn't touch anywhere, we didn't go anywhere near there. But as we pull up proximally, you can see that here comes the stent in a short while. Yeah, the stent is here. You can see those little dots there. Those bright sparks are the stent itself, and you can see it's well applied. And this is the circumflex wire that's going to the left mid. So the stent is well expanded circumferentially. Right. So these are the teaching points. Control dissection for osteostenosis is important because it's proximity, ease of passage as first choice or semi-compliant balloon, but our choice is beyond the area of target. And of course, what is important is I always tell my younger doctors to actually use a stepwise inflation to nominal pressure, 2, 4, 6, for example. There's no rush in this kind of cases. And then subsequently, you can go up to higher pressures or supranormal pressures. So, but what is important is a stepwise inflation. And this is important if you have a calcium spicule, for example, that won't open. If you suddenly go up to very high pressures, you can cause perforation. And this has happened several times in the past. So just feel like it's safer to do a stepwise inflation. Imaging is useful because you want to see the morphology, as I mentioned earlier. If it's a calcific ring, we call it a napkin ring kind of lesion. You shouldn't really be trying, because if anything happens, you don't have a bailout plan, because you can't put the stent into the area or the target area anyway. So IVUS imaging is also important in this aneurysmal segment, because it gives you an idea what the size of stent to use and what is an NC balloon for post-stent optimization that you should be used. So again, IVUS identifies thrombus, so it adds a sense of urgency and what drugs to use. And because of this, also this is the reason why we use ticagrelor as well as clopidogrel for this patient. So that's pretty much the first case. We move on to the second case. The second case, again, to illustrate that small lesions are important in deciding your balloon's selection. If you are choosing a balloon which is a scoring balloon, you should choose one which has a good crossing characteristic. And of course, the wedge has a good crossing characteristics. We also wanted to illustrate that you can use a long wedge balloon, 20 millimeter wedge balloon, as opposed to a 15 or even shorter, just to show that it's quite trackable and is able to cross quite well. Now, up front, we have a decision to make to have a use of DCB. So DCB from upfront. It's good to have a decision about whether you want to use stent or whether you want to go for DCB, because once you decide to go for DCB, then the lesion preparation must be very meticulous, because it has to be very, very good. Now, the reason is because it is not the stents affords radial strength. It can open up the vessel and stay open. However, because a DCB is only it's a non-performance balloon. It's not a structural balloon. It is just a balloon that's used to carry the drug to the vessel. So it's just like a paintbrush. So the DCBs or DEBs are actually just paintbrushes. So your lesion has to be very well prepared before you even put a DCB. So this is where it's different. This is the importance of good lesion preparation. And my default plan is for, if you plan DCB, then go straight for drug scoring balloons. So this is a 69-year-old males, diabetic. Again, we have many diabetics in Malaysia. HbA1c poorly controlled over the years. He was managed in another hospital. He's got hypertension. He's got dyslipidemia. Now there was he was planned for a surgery actually, but he was noted to have some ECG changes in the infralateral. They subjected him to MSCT in the other hospital, and they found the right coronary artery 70% stenosis. So thereon, we decided to do a coronary angiogram. And you see this coronary angiogram, a very long distal lesion right to the to the end all, but it's a very tortuous. This is not obviously seen in this view, but it actually is a three-dimensional turn, and it turns left and right, and then finally onto the distal lesion. But you can see here that there is a significant long segment narrowing, more than 30 millimeters of disease segment in a small vessel. That's important. The catheter is about 2 millimeters, and so this is under 2 millimeters in diameter. So this is the QFR. You can see our QFR measurement. We have QFR facilities, a QFR of 0.73, which obviously shows that this is a narrowed vessel. So the normal QFR is above 0.85. And so let's have a look at what the next step is. Okay, so this is the lesion again. Okay, so the strategy here is actually to use a drug-eluting balloon or drug-coated balloon. The vessel is small caliber, there is long diffuse lesion, you need a trackable scoring balloon, and you need a good vessel preparation for DCB. So this is our DCB. This is a 20 millimeter wedge balloon. You can see it's gone free. And so the size is important if you are going to look at the size. Now, I think it's important to emphasize that when you look at distance, there is always in terms of distance. So it looks to keep that in mind when you're choosing the balloon size. You don't want to choose a scoring balloon which is too big and it causes a dissection. Remember, once you cause a dissection, if it is flow limiting or type B or type C, then you have to consider putting in a stent, which is what is not the original intention in the first place. So it's good to choose the right size of balloon so that you can use your drug-coated balloon. So you must compare when you're inflated. You can see here the inflated balloon. What does it look in terms of this in comparison to the angiographic appearance of the vessel? So that gives you an idea of how accurate the balloon size is. So this is a 2.0 20 millimeter balloon. Notice we use many inflations here, and I think it should be emphasized there is no limit to the number of inflations. I think as long as it's reasonable and the balloon is tough enough to take many inflations and deflations, 4 atmospheres, remember escalating 6 to 12 a nominal and 10 atmospheres. So we went up to pressures and subsequently to the nominal of 12 atmospheres. So here is a balloon on the left to show that it has gone quite well. You can see the balloon passing quite well down into the left, on the left image, down into the right coronary artery stenotic areas quite easily. So this is after we've used our 2.0 balloon at various pressures. You can see it's opened up very well. It's not a very big vessel here, but this is good for us to put a DCB in. So this is, we've used 3 restore balloons of various diameters, 2.0, 2.0, 2.5, because it's a very long segment here. It's longer than what it really is apparent on this video, but it's a long segment. And I think important point is it doesn't matter if you overlap your DCBs. It's fine, you just get extra drug on that overlap segment anyway. So the teaching points for this case, it's DCB for small vessels, rather than stent because they are small. If you use stent, there's a risk of restenosis. And I think DCB should be an upfront strategy. You should have adequate lesion preparation because you are planning on this using a DCB. And the device shows that it is easy to pass in the tortuous right coronary artery down to the distal lesions. And this is important if you have other tortuous lesions to actually make sure you can use a device that you can deliver to that point. Again, if you have magnification issues and some vessels, some individuals have higher magnification, they look fairly bigger than what it really is, use a smaller balloon if in doubt. You can always go to high pressure. You can always upscale it to a bigger balloon if you need to. But if the balloon looks at the size of the vessel itself, then that should be enough in terms of the sizing of the balloon. If it looks smaller, then you can use a bigger balloon. So always compare the inflated balloon size to the vessel size itself. So I think maybe I can pause if there are any questions anybody wants to ask before I move on to the. I've got 2 more cases, short cases. But if anybody has any questions or queries, I can try to answer them.
Yes, thanks, Dr. Rosman.
Yes, yes.
You can hear me?
Yes, I can hear you, yes.
Oh yes, thanks for your good speech. It's very good, excellent. So here we have a little question that what's the advantage of wedge when you combine wedge with the drag coating balloon and the drag eluting stent? Yeah, that's my question.
Yes, yes, of course. Once you've prepared the lesion, you can use a segment of it, the distal segment, for example, because it's small, a drug-coated balloon, and then the proximal segment, we can use a drug-coated stent, so a drug-eluting stent. So we can, in the same sitting, use a drug-eluting balloon where the vessel is small, and use a drug-coated stent where the vessel is a bit bigger. So combine drug DES and DCB. So no problems. We've used that in many of our patients.
So the wedge, you will use it for before you dilation the lesion.
Correct. Yeah, we use it to prepare the lesion before we actually put the drug-coated balloon on drug-eluting stent. So you have to prepare it very well, especially if you want to use a drug-coated balloon, because if you don't prepare it well, then number one, the balloon won't expand very well, the drug won't be delivered very well. I like to use a scoring balloon because when it cuts into the plaque, you have better chance of the drug eluting into the endothelium and through the vessel itself, vessel wall. So it's a good idea to use a drug-coated balloon if you're thinking scoring balloon if you're planning to use a drug-coated balloon.
So you use SC more than NC, right?
We don't use we don't use SC so much. We use NC most of the time. We have SC available, but most of the time we prefer NC because it's not going to grow when we go to higher pressures. When we do need to use the scoring balloons, we oftentimes have to go to high pressures. So the NC is a better choice because it doesn't get bigger. If you use a SC, then the vessel can, when you go to higher pressures, it will grow bigger and can cause dissections. Then in that case, you have to stent them, or you need to do something else.
Oh.
So more NC rather than SC.
Okay, thank you so much. We appreciate that. Thanks.
Welcome. Any other questions? So maybe I could just finish up on the last two cases. This is case illustration number 3. Here, I'd like to illustrate again a distal lesion, but now involving the left anterior ascending artery. But this is a badly diseased ectatic vessel. So it's a small vessel, like the one that you saw, but that was the right. This is the left. But it had stented segments in the proximal part. So proximal was stented previously, a few years ago, many years ago, in fact. And the lesion now is extending beyond the stent itself to distal part. So the plan here is, because this is small, a small part of the left anterior ascending artery, small caliber, we want to use a DCB. It's a 63-year-old male. He presented with non-ST elevation MI, he had hypertension, diabetes, and has dyslipidemia. So the angioplasty was done in 2004, many years ago, but it has stood the test of time. However, because of the disease itself, it has progressed to what it is now. And you can see the lesions here on the LAD quite far down, but small vessels, but causing him symptoms. All right. There are also lesions in the other vessels, but we're going to concentrate on the LAD lesion. So he's got stents in the circumflex as well. You can see there before at the start, the stent circumflex on the left, on the right here, circumflex, and the LAD on the left. Here is the LAD lesion in a still photograph on the right-hand side. You can see the lesion is small. It's very distal to the stent across here proximally. Not a very big lesion, not a very big vessel. So these are the lesions again in another view. This is another view here. You can see again, very small vessel, but the stent is visible here on the top part, in the proximal part, but further down, very small disease segments. So these are not surgical candidates because they are small, they are diseased. The surgeons will have difficulty in grafting them. So the option is probably to balloon and then use drug-coated balloon to keep the results patent. However, the problem is what choice of balloon do you have? Should we use a normal balloon or should we use a scoring balloon? There are various types available nowadays. So my choice in this type of lesion, because they are obviously very diseased, the choice is to use a drug-coated balloon and a scoring balloon. So here is the IVUS. We managed to IVUS it because we want to be sure what is the size of the vessel itself. So it's around about 2.0 in terms of diameter. The MLA is about 1.70, which is very small millimeters squared. There's a heavy plug burden there on the distal LAD vessel. So this had to be ballooned first because it was tight with the Ikazuchi 2.0 times 10 millimeter before we put the Wedge NC 2.0 times 10 short because better pushability. The short balloon in this case, I think it's long segment, very diseased. And here we use many multiple inflations, 12, 4 times, 14, 16, and then 18, just to get the results. Now, again, these vessels are not ideal because, we don't have a choice. These vessels are diseased. Let me just show you the picture in the pre-balloon again. Just you see the side branch coming off there on the left. From there on to the distal part, all disease, in fact, and beyond. So this is the post-scoring balloon after 2.0 times 10 millimeter. You can see the vessels opened up very well. The distal part is not as small as it seems, but it's a reasonable flow, reasonable flow. But again, we've decided to actually DCB this because of the size of the vessel. You can see here, you can see that the vessel is actually opened up with reasonable flow down distally. Again, as there are distal diseases, we think that it's reasonable, it's okay because their vessels are small anyway, and DCB is appropriate for this patient. But most importantly, you can see how the vessel has opened up. The post-NC wedge balloon has managed to open up the vessel. This was the tighter lesion at 1.73 I showed you earlier on. This has opened to a mean luminal area of 5.15. So 3 times bigger now compared to what it was, which is quite impressive. And there are no areas of concern, no thrombus, no obvious large flaps. But there's some trauma involved, but I think that's acceptable. Again, the teaching point in this is it looks at distal long lesions where the wedge balloon is very important, very useful. You can get multiple ablations, no problem. The balloon doesn't get deformed. The smaller balloon may be of choice if you're not sure what size to use. And of course, the magnification is an issue again, because this is the distal vessel, distal LAD, and you can't overestimate the size. But you can see from the 2.0 balloon itself, it is the right size to the balloon, to the vessel size. So finally, we move to our case illustration number 4. And this is a 67-year-old male, triple vessel disease again, same sort of risk factors, dyslipidemia, hypertension, obesity, and high triglycerides. So previous PCI done on the right circumflex and circumflex and RCA in 2008. He had triple vessel disease, but angina, but the stress echo was normal. So he has angina, and we see that sometimes because the angina can come from very small vessels, but the stress echo, because it looks at larger vessels, can be normal. But angina can be there because no matter how small the vessels are, they can cause angina. So you can see here on the right, the image, the angiographic image of the left, the eccentric. You can see there's an eccentric plug here on the right. This is already with a wire in place, but there is a plug on the left eccentric. It's a large vessel. The plan is for a drug-eluting stent right from the word go. So this is a drug-eluting stent case, and you can see that you need to prepare this lesion well because this plug appears to be quite recalcitrant. It's quite tough. It's quite hard. We didn't do an IVUS in this case, but we used a 3.0 times 15, and we went up to 12, 14, 16, 18 atmospheres. You can go up to about 22 atmospheres and even up to 28. But we have achieved our results at 22. And again, you can see that after multiple inflations, and I think you have to be patient. You have to, in order to avoid getting dissections and then complications and so on, it's good to inflate many times until you get the cut that you need and prepare the lesion well. So after many cuts, we managed to get a very nice preparatory state for this vessel. You can see that it's quite well opened up, nice to actually put your stent in, and you can expect good results as a result of that. So we use Ultimaster 3.0 times 33 but this was subsequently upsized to a 3.5. Again, you can see here there's very nice vessel optimization compared to when it was before with the eccentric plug. And of course, we use a 3.5 for optimization. Here you can see a picture of the vessel, very nice opened up vessel compared to this patient got triple vessel disease. And so he has other lesions in the other vessels as well. But this is the LAD where we've opened up with the scoring balloon and stented. So the teaching point here, if you are unable to achieve optimization, cut out the plug from the first few times, persevere, continue to cut, and you will achieve the results. If you're unsure if it's calcium, which is the napkin ring type, then you might want to IVUS. But multiple inflations usually will do the trick. And this balloon has a high inflation, re-inflation tolerance. You can use it many times at high pressures, which is quite impressive because sometimes you can't use high pressures at balloons many times at high pressures. You can use it many times, but not at high pressures. But this one you can use at high pressures, and you gradually step up the pressure to avoid perforation risk and cut the lesion gradually to the desired results. So I think finally, I just spent a few minutes on the tips and tricks on how to use the Wedge NC balloon. You've touched on what the various points were earlier. I've touched on what the various points were earlier on. First of all, you have issues to look at in terms of target lesion, and then you decide whether or not you are going to use a scoring or cutting balloon for this lesion. So sometimes if there's no particular preference for either semi-compliant or non-compliant, it usually involves a less complex lesion. So these are usually lesions which are not so calcific, young patients, new lesions, for example, new meaning the patient's disease hasn't been around for so long. They are short lesions, for example, no diabetes, no long-standing diabetes, no renal disease. And renal disease is the worst because they get fibrocalcific and heavily calcified vessels, especially those on hemodialysis. They are very, very calcified. So here we make the decision that if you are going to use a scoring balloon as an approach, then there are certain information that you need. In fact, this information actually makes you decide. So the arrows can go in either direction. So you look at imaging features and angiographic features. You may not have facilities for IVUS or OCT, but the angiographic features already tell you that there may be calcium even before the contrast is injected. You can see shadows of calcification, for example, gives you an idea that this is a heavily calcified vessel. Again, the history of the patient, if he's got renal failure, CKD, or diabetes, age, multiple comorbidity, gives you an idea that the lesions are going to be hard, fibrocalcific, and challenging. So you might opt for scoring balloon as the initial balloon choice, or at least somewhere in the early stages of the intervention. The next thing is to decide on the size of the balloon. As I mentioned earlier on, there are several things to consider, not just two, several things to consider. One is the position, the location of target lesion, whether it's distal, the appearance of the vessel proximally, whether it's tortuous, in order for you to deliver the lesion distally, the device distally, and of course, the angiographic and imaging facility pictures, as I mentioned earlier on. Of course, the diameter of the vessel is also important for you to decide on what size to use. And again, the issues in regards to radio amplification are also important because it gives you, you have to make sure that you don't use a too big a balloon for that distal lesion. So next slide is the crossability issues. And I think you need to consider if you are unable to cross, you're using deliver the device distally, various devices, anchor technique, guide devices, guideliner devices to deliver it more distally. If you have inflated the balloon once, for example, some balloons have a expanded profile. So we have a rewrap technique whereby you can actually pull the guiding the balloon into the guiding catheter, inflate at nominal, and then deflate again. So the balloon should fall into the shape that it was wrapped in, at least for most times anyway. And then the crossing profile is better for you to actually cross the lesion without having to take out the balloon out of the catheter and use a rewrap device. Most balloons have a rewrapping device for you to actually fold it into the shape that it was before it was being used. But this technique whereby you inflate and deflate in the guiding catheter gives you a chance to re-wrap it quite fast and quite easily. So the other thing is, of course, the reuse tolerance of your balloons, which is high tolerance for reuse. And of course, the choice of smaller balloons and shorter balloons, excuse me, for lesions which are distal and small. So I think you need to, when we use scoring balloons or cutting balloons for that matter, these are devices. We have to mitigate the dissection risk. And as I mentioned earlier on, it's important to use a stepwise inflation. Inflate slowly. You can inflate rapidly if you want, but you have to be prepared for surprises. But it also depends on the condition of the vessels. If it looks as though it's a soft lesion, I think by all means go to nominal pressures quickly. But if there's difficulty and you need to cut a few times or many times, then it's good to use the initial few times at lower pressures and multiple inflations. You may decide to use a smaller initial balloon, either, for example, a small preparatory balloon, like I said, 2O of a non-compliant or semi-compliant balloon, just so that you can pass your device through, or your IVUS device or imaging device through, and then move on to a scoring balloon. Again, I can't overemphasize your radio magnification and size mismatch in some vessels, distal circumflex, distal RCA, LAD, for example. And correct sizing is important for scoring balloons. This is something which I find very useful to keep in mind. Again, of course, obtaining good lesion preparation is the mantra of all interventional procedures, but especially so if you are using drug-coated balloons, because they are not forgiving. Your drug-coated balloons, as I said, are not structural performance balloons. They are just paint brushes for your drug, and you need multiple inflations for some lesion. And this is where you really need to do it, rather than just take 2 inflations and then come out and then decide on a bigger balloon, for example. I think you must maximize your baromerification of the endothelium of the plug before you move on, for example. And I mentioned earlier on, you can rotate the wires to get better cutting location within the guide wire. Don't turn in the lesion, pull it out first into the guiding catheter and turn it in the guiding catheter. So this is an example of how this device, the Wedge NC, Wedge NC. Remember, the NC is made of a thicker polymer. It's a thicker material. So the fact that you can use an NC balloon as opposed to an SC balloon and cross lesions which are distal and tortuous means it's very good, because you expect SC balloons, semi-compliant balloons, to be able to cross anyway, because they are made of thinner material. They don't go to high pressures. But the NC balloons are made of tougher material. They can go to high pressures. So that means they are a little bit bulkier. And you can see in the earlier diagram I showed you. But the fact that you can actually cross, this is a reverse saphenous vein graft in somebody who has a bypass surgery, and he had an anastomotic lesion in the distal part here. So we put a balloon in there in the distal lesion and open it up, and he was able to track. Remember, these catheters are not engaging well because they are RSVG grafts. So the ostium of this vein grafts have no support. So the fact that you can put a wire down and just guide the score flag, the wedge device all the way down means it's quite trackable. And also, of course, we've managed to stent with an Onyx 12 millimeters, and you can see the results. So this illustrates the trackability of the wedge. And I think that's pretty much all that I have to say. Thank you very much for your attention.
If any questions to Dr. Azhari?
Thank you so much. Thank you, Dr. Azhari. Thank you for the impressive case sharings.
During the sharing of your wonderful case, I think many audience will have some question, or maybe they want to discuss with you. So just let us to see who has some question to Dr. Azhari.
Yeah, sure.
Yes.
Dr. Azhari Rosman.
Yes.
Thank you for your excellent presentation. It's very inspiring and educative. I learned a lot, and I have a question. You mentioned several times that it's necessary to do multiple inflations in some calcified lesions to have
Yes.
better lesion preparation. I want to know whether you will change the direction of the wear, scoring wear.
Yeah.
Will you turn the balloon to another direction for
Yeah,
the
yeah.
second?
Yes, that's right. Correct. Thank you for that question. Yes, I did mention earlier on that if you have a need to cut more effectively, you can actually pull the balloon into the guiding catheter and turn it while it's in the guiding catheter in another direction, 90 degrees this way or 90 degrees that way, and then go back inside and inflate again so that you direct the wire in another direction. So you can do that, and we've done that many times also. That will give you a better cut. Because sometimes if you see that the lesion is not responding because the wire is in the other direction. So you need to turn it around and make sure that you can't tell for sure, but at least if you turn it around, there's a probability that you will cut into the plug itself, because these are particularly true if the plugs are eccentric. So yes, you can pull, but don't pull it when it's inside. Don't turn it when it's inside the vessel, because you can tear the endothelium if there's a flap there. But if it's outside, you can pull it back inside into the guiding itself, turn in the guiding and push it back in.
Okay, so you suggest to turn it at 90 degrees?
Yeah, 90 degrees, fine, yeah.
Okay, got it. Thank you very much for your
Welcome.
advice, doctor. Thank you.
Hi, Dr. Azhari. Linkpa have one question to you. Do you have any experience used with heavy calcification? Can you compare with other device? Maybe it means other balloon.
Right. So yes, heavy calcifications, you have to be very careful. These are scoring balloons. The scoring balloons are the Scoreflex and your Wedge. And the Scoreflex has got 2 wires. Yours has got 1 wire. For calcifications, they're pretty much the same in terms. If they are moderate calcification, you can cut, but you may require high pressures. There are 2 instances where it will not work, these heavy calcifications. Number 1 is the napkin ring. The calcium is all around. That one is very difficult to break no matter what device that you have. That's the first thing. The second thing is the vessel, the balloon itself can open up big, but the napkin ring doesn't open. So what happens is that you can get dissections on either side of the vessel, but the ring itself is still stenosed. So then that's where the problem starts, because you cannot deliver a stent, you cannot have a bailout procedure. So these are the things that you have to keep in mind. Now, with Wedge, you can actually use high pressures. Okay, it doesn't grow very much, maybe about 9%. It grows as you go up to 28 atmospheres, for example. The rated burst is about 20, by the way. So you can try, it may crack. But some of the other balloon, that's, for example, the other balloon with metal parts, for example, the Wolverine, for example, or the NSE, the Wolverine especially, although it is a non-compliant balloon, it's a non-compliant, but the metal part itself can cut into the balloon. So you can't go very high pressure, although it's NC, but maybe 12 atmospheres is about the right. It's nominal, it's about 10 or 8 or 10. But you can't go very high, because if you go high, the blades will cut into the balloon itself. So that's with the Wolverine balloon, with the metal blades. Then the NSC Alpha is a one with the plastic blades. NSC Alpha also with the plastic, but that is a non-compliant balloon, semi-compliant balloon. It's not, you cannot go to high pressures. So the nominal is about 6 atmospheres, only 6, but we can go up to 12. We've gone up to 12 or 14. So that's our experience. Calcific lesions, if you're going to use balloons, probably the wedge type of balloons with the wires are the safer options, because these are the heavy calcification, because the other calcifications may be a bit too stiff. But the only way to know is to do an IVUS. So that's why sometimes IVUS is very important, because we have been caught a few times where the lesion looks as though it's an easy lesion to open, no obvious calcification on angiogram. But when we open it, it doesn't want to open even at high pressures, and so we stop. We say, wait, let's do an IVUS and look at this calcification. And true enough, the calcification is a type that will not open regardless of what balloon you use at whatever pressure. So you have to use either rotablation or orbital atherectomy.
Thank you, Dr. Azhari. Thanks for the splendid sharing of Dr. Azhari and BrosMed R&D team for today's webinar. Also, thanks for the support of all the audience. You can search BrosMed medical website for more product information. Any questions, you can contact us via email sales@brosmed.com. See you next time. See you.